Hi, my name is Laura Whitburn and I teach anatomy at the Bundoora campus.
In this series of videos, we're going to talk about what happens when something goes wrong with the motor control system. When there's a problem with one part of the central nervous system, how does it affect movement and why? We're not going to discuss the specific pathophysiology of different neurological disorders, but rather we're going to discuss how someone's ability to move is altered when a particular part of the CNS is not functioning properly. So, what are the functional implications of that disorder? Which part of their body is affected and in what way? Is their body part paralysed, or can they still move it but has their control of movement changed? What's interesting is that our understanding of what all of these parts of the brain do was actually based on reversed engineering. So in order to understand the normal function of each of these brain regions, we had to do so by studying a patient who had a problem with that brain region, who had damage to it or a disorder with it, and by looking at their symptoms. And by looking at their symptoms, we could work out what the normal function of that particular brain region was. So we should be very grateful to the patients who have been studied that have allowed us to understand the brain and how it works. Now this here is the diagram of our motor control system, and that shows us the interaction between the different parts of the brain when we perform a voluntary movement. So it reminds us that the association cortex is involved in the planning stage of the movement. The cerebellum and the basal nuclei are involved in the programming of the movement, and then the motor cortex, brainstem and spinal cord are involved in executing that motor program. So we will discuss in this series of videos disorders associated with the basal nuclei, the cerebellum, and with these regions that are associated with motor output. In this first video, we'll start with the basal nuclei. If we first remember back to the normal function of the basal nuclei act as a filter to prevent unwanted motor programs from being executed by the motor cortex, and then deciding when it will allow a voluntary movement to be initiated. So the basal nuclei constantly has the brakes on the motor cortex, i.e. it's constantly inhibiting the motor cortex. And then it decides when to take the brakes off or to disinhibit the correct part of the motor cortex to allow the desired movement to be performed. So when there's a problem with the basal nuclei, we're not going to see muscle paralysis, but there will be problems with initiation of movement, particularly internally generated movements, as though the brakes are stuck on. Or conversely, there may be uncontrolled movements, as though the brakes are stuck off, they're completely released. And so the motor cortex is sending lots of movement commands that usually the basal nuclei would filter out. These symptoms can be grouped into one of two categories: hypokinesia or hyperkinesia. And the movement problem that someone will have will depend on which part of the basal nuclei is affected. So let's start with discussing hypokinesia. Now, this here is our normal basal nuclei circuitry that we've discussed previously. Hypokinesia means a lack or a slowness of movement. Hypo means decreased or low, and kinesia means movement. So hypokinesia is a lack or slowness of movement or an inability to initiate movements. And Parkinson's disease is the common example of this. It's currently unknown what causes Parkinson's disease, but Parkinson's disease results in the degeneration of dopamine-producing neurons in the substantia nigra of the midbrain. Dopamine is an essential neurotransmitter that comes from the substantia nigra and fuels the input nuclei, for example, the putamen. So without the substantia nigra and the dopamine from the substantia nigra, the input nuclei can no longer function properly. So what this means is that even if a plan for movement arrives from the association cortex, this would normally trigger the input nuclei to inhibit the output nuclei. However, without its fuel, the input nuclei can no longer do this. And so the output nuclei, or the globus pallidus, will continue to inhibit the motor cortex via the thalamus. So this is our analogy where the brakes are stuck on, which means that even though that person has an intention to move, they want to move in a particular way, the brakes are stuck on and their motor cortex is being inhibited. So Parkinson's disease patients generally have a slow or shuffling gait, and they may have problems with initiating the first step when they want to start walking. The other key symptom of Parkinson's disease is a resting tremor. This is a tremor, particularly in the hands, that is only present at rest, as well as a rigidity of their body. And both of these symptoms are due to a co-contraction of agonist and antagonist muscles, which causes limbs to be very stiff, and it may cause the tremor at rest because the agonist and antagonist muscles are pulling that body part back and forth in an attempt to keep it still. So the opposite type of movement disorder is hyperkinesia, which means an increase in movement, and excessive or abnormal movements. So hyper meaning increased or high. This can result from a number of different problems. One is a stroke that affects the subthalamic nuclei, and another is a disorder called Huntington's disease. Huntington's disease is a genetically inherited disease that involves a defective gene, and this results in the gradual degeneration of neurons that are part of the basal nuclei circuitry and usually help the basal nuclei filter unwanted movements. But let's use stroke as an example. And so if there's been a stroke that's affected this subthalamic nuclei, let's see what happens. So the subthalamic nuclei usually provide the fuel for the globus pallidus, so it allows the globus pallidus to do its job, or the output nuclei. So without this fuel, the globus pallidus will stop doing its job, which is to inhibit the motor cortex via the thalamus. And so as a result, without this inhibition of the motor cortex, there will be overactivity in the motor cortex. And this activity of the motor cortex is a whole lot of random and unintended movement commands that are being sent to the body. Symptoms might start with twitching of different parts of the body or twitching of the facial muscles, and can then lead to symptoms such as ballism, ballistic movements are flinging type movements of the limbs. It can even be associated with abnormal movements called chorea movements. Chorea means dance, like in the word choreography, and chorea movements are writhing or dance-like movements that are involuntary but are a real hallmark of particularly Huntington's disease. I'd now like you to watch these two YouTube videos. These are videos of real patients with Parkinson's disease and Huntington's disease, and will enable you to actually put into reality these concepts that we've been talking about in relation to the basal nuclei. For each of the patients, I want you to write down what movement disturbances you're observing that each of these patients is displaying. And in relation to the circuitry of the basal nuclei, as we've just discussed it, briefly explain the reasons for these movement disturbances. You can post your ideas on the discussion forum for some feedback.